Good afternoon and good evening, everyone. My name is Fiona Fennessy, and I'm just going to be the host this evening and introduce our two speakers, Atul Shinagare and Lucas Torres. And before I start and before I share my screen, I just wanted to let everybody know that this is our first joint webinar with the SPR, the São Paulo Radiological Society. And thank you to Marcelo Queiroz for his support in establishing this collaboration. We are very delighted to welcome our colleagues from Brazil to this symposium, and we look forward to jointly hosting future events. So I am just going to share my screen. So welcome. So today we're going to have our ICIS webinar is focused on onco-gynecological imaging. Specifically, we're going to have Dr. Atul Shinagare speak about O-RADS. Atul is from the Brigham and Women's Hospital in Boston. And Dr. Lucas Torres is going to talk about imaging of peritoneal carcinomatosis in ovarian cancer. And he is from the Federal University of São Paulo. And just a few announcements. We'd like to thank our corporate sponsors, Siemens Health, Aneers, and Bracco. For any of you who are interested, if you would like to sign up to our monthly e-newsletter, you can find out about these webinars, online courses, articles published in cancer imaging, and much more. And this is the code if you just want to take a quick photo of it, or you can go to the ICIS website. This is to let you know that the 24th ICIS meeting and annual teaching course is going to be on in The Hague in the Netherlands next September. And the theme is Precision Diagnostics, Advancing Oncological Imaging Breakthroughs. And the president is Thierry Huisman. You can also register by emailing this Cancer Imaging Society email address here, and then they will let you know when registration is open. Just to also let you know, if you're interested in a masterclass in head and neck cancer imaging, that is coming up that actually was already on the Thursday and Friday, November 25th, but we do have a hands-on case-based computer workshop online 2 half days. So that's specifically on head and neck imaging. And you can also, if you go to these links and hashtags, you can tell us the type of programming that you're interested in. So now I'm going to turn you over to Dr. Atul Shinagare, who's going to be the first person to speak. Atul is going to focus on O-RADS. So thank you, Atul, for doing this. And just to let participants know, if you have any questions, you can put them in either the chat or the Q&A, whichever is easy for you, and then we will address them probably at the end of both sessions when both speakers are finished. So thank you, Atul.
Thanks, Fiona, and thanks for joining today for this webinar. I had a pleasure of being in Sao Paulo maybe 3 years ago for JPR meeting and had a wonderful time, fantastic city, and great, it was a really great experience. So over the next half an hour or so, I'll focus on O-RADS. As you know, it's a pretty large topic. I'm going to cover both O-RADS ultrasound and MRI, and each one can be an hour-long talk. So I'm going to focus on big picture, some practical tips if you're using it in your clinical practice. And I won't be going through every single detail, but rather focus on overview. I have no relevant conflicts of interest. So I would encourage everyone to visit the O-RADS website, where there are a lot of resources on ultrasound and MRI, and I'm going to go over some of them over the next half an hour. So we know that adnexal masses are common, but majority of them are benign. And ovarian cancer is the second most common gynecological malignancy. Majority of these patients present at an advanced stage where the prognosis is not great. So if we can detect this early, that's great. But as much as we want to detect lesions early, we also want to avoid unnecessary imaging or surgery, which means every time you see an adnexal lesion, if you start getting additional imaging or send patient for surgery, obviously that's not going to work well either. So we need to have that fine balance. So that's where O-RADS plays a role. O-RADS stands for Ovarian Adnexal Reporting and Data System. It's a multidisciplinary collaboration between radiology, gynecology, pathology, and gyn-onc. And people from United States, Canada, Europe, and UK participated in it. It's a standardized lexicon for describing ovarian and adnexal masses. It provides evidence-based risk stratification and management system, especially for ultrasound, the management part. The goals are to improve report quality and communication between radiologists and referrers, to limit the variability in the reporting language so that all our reports get standardized, and to guide the management in terms of optimal imaging evaluation and in avoiding unnecessary surgery. Ultrasound is the primary imaging modality, and MRI has a problem-solving role. So our outline is very easy. We are going to talk about O-RADS ultrasound, the newer 2022 version, and O-RADS MRI. So let's start with ultrasound. Within each ultrasound, O-RADS ultrasound and MRI, we'll talk about some governing concepts, lexicon terminology and definitions, assessment categories. For O-RADS ultrasound, there is also management part, but I really won't be focusing on that, but rather focus on the assessment part, and then the algorithm and some resources. All right, so just to give some background, the O-RADS committee was formed in 2015. The first version was published in 2019, updated in 22. The newer update resolves some of the discrepancies between O-RADS MRI and ultrasound, and also with the SRU consensus statement. And it allows incorporation of O-RADS ultrasound to pelvic report templates for all patients if desired. So basically, the effort is to make it more inclusive, to make it more generalizable, and to improve the specificity of certain low-risk lesions so that if they are getting investigated, at least they have a high specificity because we want to reduce the unnecessary imaging and surgeries. And it also strengthens the management recommendations. So what are the highlights of governing concepts? First thing we need to know is applicability. When do we use O-RADS ultrasound? We should use it if we are looking at ovarian, fallopian tube, or paraovarian lesion with the intent to stratify the malignancy risk. We can use it to describe normal ovary and also use it in high-risk patients and those with presence of symptoms. Now, this is different from O-RADS MRI. For ultrasound part, we can use it in these patients. Now, where do we not use it? We don't use it for PID, pelvic inflammatory disease, ectopic pregnancies, torsion of the normal ovary, and for clearly non-ovarian or non-tubal lesions, such as pedunculated or broad ligament fibroid. And if you're not sure about the exact origin of the lesion, you can consider CT or MRI. O-RADS is not applicable if the ovary is absent or it's not visualized. But there's one fine point. O-RADS 0 means technically inadequate. So what's the difference? Now, if you expect to see the ovary based on the indication and you cannot find it, then you say it's technically inadequate. We need to know the definition of menopausal status. Postmenopausal is amenorrhea for more than 1 year. And if it's early, within 5 years, it's early postmenopausal status. If it's 5 years or more, it's late postmenopausal. And if you're not sure about the last period or if the uterus is absent, then you use age. 50 is the cutoff. In terms of technique, transabdominal ultrasound is maybe enough if the characterization is adequate, but we strongly encourage, and in most cases, we need transvaginal ultrasound. Cineclips are not required, but strongly encouraged, and most centers do get cineclips. And in terms of size, we use a single longest dimension in any plane for risk stratification. But if you're serially following up a lesion to see change in size, 3 dimensions are often helpful. So those are some of the big picture concepts. Now let's talk about some key lexicon terminology and definition, especially the updates. So one major update is creation of this bilocular category. Now in the older version, if a lesion had even a single septum, that would become a multilocular lesion. But now we know that these bilocular lesions have low risk. So now in the 2022 version, there's a separate category for bilocular lesion. And you'll see it appear in multiple different categories, and we're going to see some examples later. Another thing is shadowing, something to remember. Shadowing can be diffuse or broad. But important thing to remember, if you see this edge artifact or refractive artifact, that is not shadowing. Now, the shadowing is present in fibromatous lesions, and typically it indicates a low risk. These fibromas, fibrothecomas usually have a smooth outer margin and shadowing. And again, these lesions with shadowing appear in multiple different locations, and we'll talk about this later. So those are some key updates and terminology to keep in mind. Now, this is where we are going to spend most of our time, assessment categories. Now, if you were to divide these lesions into sort of big, broad buckets, there are three ones that we should consider. Starting with the easiest, physiologic lesions like follicle corpus luteum, that's normal, O-RADS 1. This is very easy. Now, second broad bucket is classic benign lesions. Now, these lesions have no internal vascularity. They can be ovarian or extra-ovarian. Now, if they're ovarian lesions, they can be O-RADS 2 or 3 based on size. If these lesions are less than 10 centimeter in size, they're O-RADS 2. 10 centimeter or more, O-RADS 3. And just the risk is higher because it's a larger lesion, we may miss something tiny. That's why as a sort of more as a precaution, they put in a higher class. Now, what are these lesions? Starting with hemorrhagic cyst. Typically, unilocular lesion, and they have this kind of typical fine reticular pattern or a retractile clot. Dermoid cyst, again cystic, it can be up to 3 locules, and it has hyperechoic components with shadowing or lines and dots or floating echogenic spherical structures. These are typical findings of dermoid cyst. And then endometrioma, again up to 3 locules. It can have ground glass appearance, like this homogeneous low-level echo. You just see it and you know it. It's very typical. It typically has smooth inner wall and with or without peripheral punctate echogenic foci. So all these lesions are classic benign lesions, and they fall into O-RADS 2 or 3 based on size. Now, extra-ovarian lesions, they're all O-RADS 2. And that includes para-ovarian cyst. Basically, it's a simple cyst outside the ovary. Or it could be peritoneal inclusion cyst. It's a fluid collection lesion with ovaries suspended at the margin. The lesion can be a little bit irregular. It conforms to the adjacent pelvic organs. It may have septations from adhesions. And then hydrosalpinx, which is anechoic, fluid-filled, tubular structure. It may have those incomplete septations or endosalpingeal folds. Now, these lesions are O-RADS 2. So that was the second big bucket. And then everything else, and for ultrasound O-RADS, it's quite complicated, to be honest. We have to look at multiple features. If it's a cystic lesion, you look at whether there are solid components. Is it smooth or irregular? Is it unilocular, bilocular, or multilocular? And then finally, you look at size, color score, and papillary projections. For solid lesion, you look at whether it's smooth or irregular and whether there's shadowing or color score. And I'm going to talk a little bit more details later with examples. Now, color score is subjective, but it helps in lesion assessment. And this is kind of like an easy way to remember some of the things. For example, color score 1, that is, you're not going to see any flow. These lesions are O-RADS 3. If color score is 2 or 3, mild to moderate, then shadowing plays a role. Earlier, I mentioned that shadowing is typically a low-risk feature because it's seen in fibromas, fibrothecomas. So if you see color score 2 or 3 with shadowing, it's O-RADS 3. If there's no shadowing, slightly higher risk, O-RADS 4. And if it's color score 4, that is very vascular, or if it's an irregular lesion, it's O-RADS 5. So let's look at each category and see some examples. So O-RADS 2, simple cyst. It's very easy. It's like very typical appearance, very thin, almost imperceptible wall, no internal structures, and all those things. You may have a cystic lesion, unilocular lesion, but it's not exactly simple. You may have a tiny, like few internal echoes or like tiny echogenic focus along the periphery. Even that falls into O-RADS 2. You could have a bilocular cyst without any other complicating feature. That's also O-RADS 2. And then we also saw these typical benign features earlier. They all are part of O-RADS 2. So this is a pretty easy category. Now, O-RADS 3, the risk is a little bit higher. It's about 1 to 10%. Now here we have a simple cyst, which is very large. Now, just because larger size, you may miss tiny features. That's why it gets put in this class. But otherwise, it's basically just a simple unilocular cyst. You may have an irregular unilocular cyst. That's O-RADS 3. Or a multilocular cyst, but it has to have smooth walls, less than 10 centimeter in size, and color score less than 4. Now, one thing to remember, when you're talking about smooth and irregular, for cystic lesions, you're looking at the inner wall. For solid lesions, you're looking at the outer margin. But anyway, if you have these multilocular lesions, which are smooth, less than 10 centimeter, less than 4 color score, they are part of O-RADS 3. And then if you see this solid with smooth margin, solid lesion with smooth margin, if it's color score 1, it's O-RADS 3. Or if it's color score 2 or 3 with shadowing, because those are almost always fibromas and fibrothecomas, that's also O-RADS 3 because those are low risk lesions. Now, O-RADS 4, the complexity level rises, and these are like sort of intermediate risk lesions. And that includes a bilocular lesion, but with irregular margin, or a multilocular lesion that does not have solid component, but either it's more than 10 centimeter in size, or color score is 4, or it's irregular. So these are like sort of worrisome features that bumps it up to our category 4. Or it could be uni or bi or multilocular lesion with a solid component. Most of those fall into O-RADS 4. I'm going to talk about a couple of exceptions on the next slide. And then we have these solid lesions, smooth, but now these are color score 2 or 3 without shadowing. Lesions with shadowing were O-RADS 3, lesions without shadowing, O-RADS 4. And now O-RADS 5, that's a high risk category, more than 50% risk of cancer. It's either a unilocular lesion with 4 or more papillary projections like that, or it's a multilocular lesion that may have solid component or color score 3 or 4. Or it could be solid lesion with color score of 4. Again, like these are all high risk features. Or a solid lesion that's irregular, that has irregular outline. Or presence of peritoneal nodules. All these are high risk features. That's why they are part of O-RADS 5. So what's the algorithm? Now, there is a very helpful algorithm on the website, O-RADS website. Now, I said helpful. I did not say it's easy. It's pretty complicated. But the thing is, once you start using it in your practice, it gets easy over time. So obviously, there's normal ovary, classic benign lesions. We already know that. That part is very easy. If it's a cystic lesion, you look for solid component, whether it's smooth or irregular, uni or bi or multilocularity, and then size, color score, papillary projections. And that's how you sort of classify these between O-RADS 2 and 5. If it's a solid lesion, you look at smooth or irregular, and then shadowing and color score, and you get O-RADS 3 to 5. And then to make it even a little bit more easy, there are some resources on the O-RADS website. There's this very helpful ACR guidance app. This is probably the easiest way to get started. It's basically just walks you through how to characterize these lesions. There's also resources about how to report these and sample report templates with 2 different formats depending on your style. And you can adapt this and use it in your practice. So that part was O-RADS ultrasound. Now, O-RADS MRI is a little bit easier actually. So again, we are going to go through the same things, some governing concepts, some lesion terminology, just the highlights, the important stuff, and assessment categories, algorithm, and resources. So first, when do we use it and not use it? We use this for patients with average risk and no acute symptoms. That's where O-RADS MRI is applicable. We also need to get the right protocol because without that, we'll be lost. So we need this T2 weighted images, T1 in and out of phase images, diffusion, and either dynamic contrast enhancement, which is preferable, and I'll show you later why, or at least if you're using non-dynamic, you need like 3 runs, but the 30 to 40-second run is the most important. That's the one when we use for assessment. So a couple of things about terminology. Solid tissue. This is often sort of a little bit confusing. Now, when you say solid tissue, it has to be enhancing. And then there are different morphologies. It can be papillary projection, it can be mural nodules, or it can be irregular wall or septation, or just solid enhancing portion. Any of this qualifies as solid tissue. Now, other solid component means smooth walls or septations, clot, debris, fat, or rocket and skin nodule. All of that is solid component. And when you say solid lesion, it includes at least 80% of solid tissue. When you say enhancement patterns, on dynamic contrast enhancement, there are three patterns. One is low risk, that's O-RADS 3, which is minimal sort of gradual enhancement, no shoulder, no plateau, just slow, mild enhancement. That's O-RADS 3. Now, intermediate risk, O-RADS 4, is moderate enhancement, but less than myometrium. And there is a plateau, there's a bit of a shoulder forming now. And then high risk curve, that is O-RADS 5, is marked enhancement, more than myometrium, there is a shoulder and there's a plateau. So these are the typical curves. If you don't use dynamic contrast enhancement, then you have two options. You look at 30 and 40-second image, and then if the enhancement is equal to or less than outer myometrium, it's O-RADS 4. So you cannot assign O-RADS 3 if you don't use dynamic contrast enhancement. And if the enhancement is more than myometrium, then it's O-RADS 5. All right, so now we get to the bulk of this MRI assessment categories. So again, the first very easy bucket is normal ovary, either no lesion or follicles, corpus luteum, hemorrhagic cyst like less than 3 centimeters in a premenopausal woman. All of those are O-RADS 1. Now, second lesion is lipid-containing lesion. If you see a lipid-containing lesion like this, it drops out. There's no enhancing solid tissue. You may see rocket and skin nodule. It's O-RADS 2 because those are just simple benign dermoids. Now, if you see a large amount of enhancing solid tissue like here, again, we have component of fat, but there's also a lot of enhancing solid tissue. That is high risk because that could be malignant. That's O-RADS 4. Now you may ask, okay, how much is large amount of solid tissue? Is it like 1 centimeter, 2 centimeter? Well, unfortunately, there is no definition. It's your just subjective assessment. There are studies being done, small studies even being published to study this, to see how large is actually large, but we don't have a real answer yet. Now, dilated fallopian tube is the next category. Again, there's no enhancing tissue. If it is a thin walls, simple fluid like this, it's O-RADS 2. If there is thick wall or a non-simple fluid, like in this case, it's O-RADS 3. And then the last sort of other bucket is peritoneal disease. If you see peritoneal disease, you consider it O-RADS 5. And then everything else falls into a like we are going to discuss the other lesions. But these four are very easy. You see this and you just know the answer. All right, so now let's look at some examples. O-RADS 2. This includes unilocular simple cysts. These are typically T1 hypointense, T2 hyperintense, very easy. If it's unilocular sort of endometriotic fluid, that is T1 hyperintense, typical T2 shading, that's also O-RADS 2. If you see a lipid-containing lesion, no large enhancing solid tissue, you may see rocket and skin nodule, dermoid, again O-RADS 2. Now, if you see solid lesion, but it's dark on T2 and dark on diffusion, that's a fibroma, fibrothecoma. That's a benign lesion, again O-RADS 2. So that's the typical T2 dark, TWA dark appearance. If you see hydrosalpinx simple fluid, O-RADS 2, and paraovarian cysts, again O-RADS 2. So these are the examples of O-RADS 2 lesions. What about MRI O-RADS 3? That's a little bit low risk, but still about up to 5%. You may see unilocular hemorrhagic fluid. It may have variable signal, but in late subacute stage, where we commonly see these, it's hyperintense on both T1 and T2 images. Or you may see a multilocular lesion, no enhancing solid tissue, or low lipid content, just simple like sort of multilocular lesions. Most of them fall into category 3. Or you may have a solid lesion with low risk curve like this. All these are O-RADS 3. And also fallopian tube, whether there's either thick walls or non-simple fluid. In this case, this was parasalpinx. Now, intermediate risk, this is about 50% risk of cancer. These are the lesions with solid tissue. an enhancement equal to or less than myometrium or intermediate risk curve. Or it could be, like we saw this example earlier, lesion with lipid containing lesion with large amount of solid tissue. These are examples of MRI O-RADS 4. And then very high risk lesions, these are almost 90% cancer, are lesion with solid tissue with enhancement that is greater than myometrium or high risk curve, or those with peritoneal disease. So these are the examples of different categories. Now, why do you need this DCE or in phase, out of phase? Can we get by without it? How does that affect our performance? Let's see an example. We saw this lesion, it's a cystic lesion with enhancing soft tissue. We see a little bit of enhancement here. On sagittal, we see definitely enhancing tissue. Diffusion is restricted. Now, if you were to categorize this, you'll say this is O-RADS 4. Lesion has a solid tissue enhancing, and we didn't have DCE here. So basically enhancement equal to or less than myometrium. This is O-RADS 4. So there's a 50% risk of cancer. But hey, actually, we did have DCE here, and that was a low risk curve. That means you can say, okay, this is not O-RADS 4, but this is a low risk enhancement curve. That means this is O-RADS 3. Now you're saying risk is not 50%, but it's 5%, much more likely to be benign. But then we also had in and out of phase. Now, if you add this, this is dropping out and out of phase. So this is like microscopic fat. And this actually counts as O-RADS 2 lesion, lipid content, no large amount of enhancing tissue. Now you're saying the risk is not 50%, not 5%, but only 0.5%. Just by having the right protocol, instead of classifying the lesion as O-RADS 4 and potentially getting surgery, we were able to avoid it and say this is O-RADS 2, almost likely benign. And this patient was just being followed, and this lesion hasn't changed. So that's why we need to get the right protocol. Now, the algorithm, again, there's an algorithm on the website. This one is much easier compared to ultrasound. Again, we have the normal ovary. We saw these buckets earlier. Normal ovary, lipid content, that's O-RADS 2 or 4. Dilated fallopian tube, O-RADS 2 or 3. Peritoneal disease, O-RADS 5. And then lesions without lipid content. If it's a cystic lesion, usually it's O-RADS 2 or 3, based on unilocularity or multilocular, wall enhancement, and type of fluid. If it's a solid lesion, it's O-RADS 2 to 5. If it's T2 and diffusion dark, it's O-RADS 2. Otherwise, depending on the enhancement of the solid tissue, it's O-RADS 3 to 5, depending on which curve it is. So this is much easier. We have similar resources on the website. We have this O-RADS MRI calculator, which is not officially part of ACR, but it's endorsed by ACR, which is very helpful, very easy to use. There are documents about how to report it, report templates that make it very easy. And ACR has also developed this MRI primer that pretty much walks you through. It's like a teaching module. It takes about a couple hours to finish it, but it's very helpful. Now, one last thing, complementary role of ultrasound and MRI. Now, both have excellent performance. MRI is a problem-solving tool. It's more specific than ultrasound, and it often correctly downgrades or upgrades lesions that are seen on ultrasound. For example, this lesion was seen on ultrasound. It was O-RADS 4 because it's a multilocular cyst, no solid component, but irregular sort of wall. It was larger than 10 centimeters. I think it was larger than 10 centimeters. But based on this irregularity, it was classified as O-RADS 4. But then we got MRI, so risk would be 10 to 50%. But then on MRI, it was a simple, basically just a multilocular cyst. There was no lipid, no solid tissue. And so this was called as O-RADS 3, which is a low risk lesion. So MRI was correctly able to downgrade it to a more benign category. That's why MRI is helpful. So in conclusion, O-RADS offers like a standardized lexicon, risk stratification, and management system. Ultrasound is the primary imaging modality, and MRI has a problem-solving role. There are many resources available on the O-RADS website. Please use them. When it comes to ultrasound, it's applicable to high-risk patients, those who are symptomatic. It does not apply to PID, ectopic, or torsion of the normal ovary, or pedunculated or broad ligament fibroids. Classic benign lesions are O-RADS 2 to 3, and for other lesions, you follow this algorithm. And for MRI, cystic lesions without solid tissue are always O-RADS 3 or less. Lesions with lipid content are stratified by the amount of solid tissue. They are O-RADS 2 or 4. T2 and diffusion dark lesions are always O-RADS 2. Enhancing solid tissue can be stratified based on enhancement between O-RADS 3 to 5. And if you see peritoneal nodules or irregular thickening, peritoneal thickening, that's O-RADS 5. Thank you.
Great, thanks very much, Atul. Next up, we're going to move to Lucas Torres from the Federal University of São Paulo. And just to remind our audience that if you have any questions, you can put them in either the chat or the Q&A, and we will address them at the end. So thanks again, Atul, and over to you, Lucas, if you can screen share. Thank you.
Thank you very much for having me. Are you seeing my screen? Good. Thank you very much for having me. My talk is about imaging of peritoneal carcinomatosis in ovarian cancer. I have no disclosures. My objectives are review the role of imaging methods in the primary staging of ovarian cancer, with emphasis on high-grade serous neoplasms. Review the limitations of calculating the peritoneal carcinomatosis index, PCI, performed by imaging methods, and mention some suggestions for preparing a radiological report. Things to know about serous epithelial ovarian cancer. It's a silent disease. 70% of cases diagnosed when there is supra- and inframesocolic peritoneal extension. It's a lethal disease. Advanced tumors, 5 years survival rate between 17 and 13%. 8% will recur. And complete surgical removal of the tumor, best chance of survival. It's useful to know the 4 possible outcomes from an ovarian cancer surgery. First, complete cytoreduction, no residual macroscopic tumor left in situ. Optimal cytoreduction, residual tumor up to 1 centimeter. Suboptimal cytoreduction, residual tumor larger than 1 centimeter. And not feasible, it's a non-resectable disease. Only complete cytoreduction and optimal cytoreduction improve survival and can benefit the patient. So, how can the surgery outcome can be predicted? Is there any way to do it? Yes, we should use the surgically evaluating the PCI. PCI divides the peritoneal and intraperitoneal organs into 13 regions. The boundaries of these regions are 2 vertical midclavicular lines and 2 horizontal lines, one anterior to superior iliac spines and the other under the costal arcs, dividing the abdomen into 9 regions. The small bowel is assessed as a separate entity and is designed as region 9 to 12. For each region, an estimation of tumor volume is performed using 4 categories. First, 0, no tumor is identified. 1, minimal volume. 2, moderate volume. And 3, gross volume. The sum of each region score comprises the PCI score. As a general rule, a PCI up to 10 is assumed to be low, up to 20, moderate. Surgery colleagues are optimistic about operating on those cases whose PCI is around 10. In my experience, those around 15 are taken to a multidisciplinary meeting for a decision. Up to it, the patient is referred to chemotherapy. But what is the principal surgical PCI drawback? The surgeon decides at the surgery moment if the extent of peritoneal dissemination permits a complete or an incomplete extirpation of the tumor. If the patient fits on those cases where surgery is not feasible, the process of decision done only at the surgical act would have been done at the expense of money, resources, and time. Any complication that arises from a surgical procedure not done for a complete surgical removal will occur at the expense of time to the beginning of treatment. Laparotomy is not the only way to predict resecability. We can also use laparoscopy. There is the Fagori score that uses 8 parameters. She is Mrs. Anne Fagori, who created this score. It's a laparoscope score. A Fagori score more than 10 predicts residual disease with a high degree of accuracy. There are limitations for the lesser sec and mesenteric root evaluation, and it continues to be a surgical procedure with all costs and time involvement. Having said that, I would like to shed some light on the importance of our radiological analysis by predicting by image which patient should go and which patient should not go for an upfront cytoreductive surgery. We can help save cost and time by allowing surgeons to avoid unsuccessful primary surgical management. Our efforts should be done to calculate PCI by imaging. And why PCI and not Fagori? Because PCI is the most studied strategy with images, and they score with more external validation studies done until now. I would like to reinforce that for ovarian cancer, 2 patients at the same stage could be treated differently, and the PCI is one of the drivers of the differences in the treatment approach. But everything seems easy until you try to calculate the PCI. And it's the first limitation of imaging PCI, which is which. And to clear up some doubts, I brought up some questions on the topic. So in which region will you fit this ovarian pelvic lesion? Trial chances? Right? It's a common error in the interpretation of PCI to assume that because the lesion projects into more than one region, it must be counted twice, as in show on B and C options. The best answer is region 6, 3 points. It's always important to return to the original document and understand what the author defined as the content of each one of the regions. Have this document on hand when analyzing the images. Region 6. Let's try another one. What would an 18 centimeter omental mass be classified as? Trial chances, again. The best answer is region 0. Again, the original document can help us showing that the region 0 comprises the great omentum. And continuing with our questions, which one of these 2 patients is more likely to obtain a complete cytoreduction? The one with a PCI of 6 or the one with a PCI of 14? Trial chances, again. So certainly, those whose involvement occurs in the lower medial regions will have complete cytoreduction. This is to keep in mind that the weight of the regions are not equal. The most important region to define whether complete cytoreduction will be possible or not is region 2, which contains the lesser sac, the gastrohepatic ligament, and hepatic hilar structures. So why this region is so important? See the complexity of anatomy of the lesser sac. So many vital structures enclosed in a small space. A lesion larger than 1 centimeter on the lesser sac reduces the chances to obtain a complete cytoreductive surgery. In a case like this, no surgical approach is possible, as there is already an infiltration of the hilar plate of the liver, as shown by the yellow arrows. So, what matters most? Some authors state that these regions are the main ones to be evaluated. Regions 2, 9, 10, 11, 12. This segmental assessment of the regions is called optimized PCI. Therefore, it's worth reviewing the sensitivity and the specificity of CT for identifying lesions in each region. Note that in part of the main regions, sensitivity is low, and sensitivity is even lower when stratifying lesions by size, when values between 15 and 25 are reported for lesions smaller than 0.5 centimeter. Some studies point to the superiority of MRI over CT in the evaluation of the main regions. See an example of an undetectable perihepatic lesion well seen by MRI diffusion. So, what is the best exam for PCI estimation? And what is the best exam for surgery outcome prediction? The literature on the best imaging method to evaluate carcinomatosis is broad and not always clear. Some results not always in agreement. Sometimes point to PET-CT as the best strategy, sometimes to MRI. Luckily, 2 important societies recommend that either one of the methods could be used. For my part, among the 3 methods, CT, PET-CT, and MRI, I prefer MRI. And recently, the ISAAC study assessed the prediction of non-resecability and concordance between the imaging and surgical PCI index by using 3 different methods: ultrasound, MRI, and CT. And in this prospective multi-center study with 244 patients, ultrasound had the higher agreement with surgical PCI and was non-inferior to CT for non-resecability prediction. The authors of ISAAC study argued that neither imaging method is superior to predict non-resecability, and the choice should be based on the expertise of each imaging method at the cancer center you are. Moving away from the theoretical part and going into a practical one, I would like to share some clues for report the lesions. We have to pay the bills, we have to write the report, and I would like to share some clues. I divided this matter into 4 topics. First one, identifying lesions. Analyze the images according to the physiological fluid flow, initially in the coronal plane and then in axial plane. I think it makes it easier for lesion detection. Second, another clue, it's useful to have a normal exam as an example, using it as a reference for your interpretation, seeing those exams side by side to compare. In this case, my colleagues and I, it became clear to my colleagues and I that there was a mesenteric root infiltration with tissue involving the superior mesenteric artery when I compare with this normal exam. Another clue is use the ovarian cancer reporting lexicon. Variation in terminology can lead to ambiguity and inconsistency in clinical radiology reports. When describing, it helps to consult the lexicon created by ESER. The lexicon has 6 major categories of terms: I will talk about one of those categories, peritoneal carcinomatosis specific. A lesion can be defined by its morphology, by its size and topography. A lesion should be called as a nodule when rounded or irregular tissue, well or poorly defined up to 3 centimeters. And a lesion should be called as a mass when rounded or irregular tissue, well or poorly defined, greater than 3 centimeters. If a mass or a nodule is located on the parietal peritoneum or on mesentery, it should be called as carcinomatosis. And if a nodule or a mass is located on visceral peritoneum or visceral surface, it should be called as an implant. Let's see some examples. A 1.5 centimeter nodular implant on the visceral surface of the liver. Let's remember a nodule on region 2, score 2. And this is carcinomatosis, identified by a 4 centimeter elongated mass lesion in the subdiaphragmatic space, infiltrating both the parietal diaphragmatic peritoneum and diaphragm muscle. Third step, write what you see. Sometimes words don't come easy, so it's useful to use a structural report. It's something my colleagues and I have done, a structural report that is a checkpoint for the most important structures to be evaluated in each region, leaving room for some comments and for the final score. I will send this model by a link and be free to download it, to use it, and to share your improvement suggestions. And moving for the last topic, conclusions, and so what? I use this phrase in the conclusions of my reports. The imaging findings suggest secondary peritoneal involvement that occurs at a low, moderate, high index. When the involvement occurs only in the inferior regions, the conclusion is the imaging findings suggest secondary peritoneal involvement that occurs at a low index. When only the inferior and medial regions are involved, I use moderate index. When one or some of the most important regions are also affected, I use moderate plus high index. These are the most difficult cases, in my opinion. I would like to share one case, an example of a moderate index of carcinomatosis, which lesions did not affect the region 2. See, region 2 is clear, right? But involved the region 1. About this case, I would like to demonstrate the involvement of the bare area of the liver, a region that is difficult for surgical management. Be aware for this kind of perihepatic lesion involvement. In cases where the involvement of those regions, that is the most important regions, occurs when the involvement of those regions occurs with tiny lesions, I put on the report moderate plus high index checked not for the size of the lesions, but by the location of the lesions on the superior or mesenteric regions. So that's in conclusion, PCI guides the treatment of ovarian lesions. The report must seek to somehow quantify the PCI. PCI, 13 regions, some more important than others, and imaging method, wherever you have, use it wisely. Thank you. I will share the link to the structural report. Thank you very much.
So thank you very much. So I do believe this webinar is also going to be recorded if you want to replay the information that you're getting and take a look on your own time as well. You're very welcome to do so. So we have a couple of minutes if anybody has any questions. And in the meantime, Atul and Lucas, do you have any final comments that you want to make? Atul?
No, this was really great. I'm glad for the opportunity to speak in front of this group. Thank you.
Great, thank you. And I have one question for you here, Lucas. How do you measure peritoneal implants in the axial or coronal plane? Do you
Axial plane.
Axial plane, okay. Another question here. If it is a cystic met, this is from Khaled in Saudi Arabia. If it is a cystic met, is T2 superior to DWI?
Sorry, I didn't understand the question.
Sure. I think what he's saying, Khaled, you can clarify there if you want on the Q&A. I think what he's saying is if a met is cystic, are you better off? What is the best way to detect it? Is it with T2 weighted imaging or with diffusion? What do you think? Either?
Either.
Either. Yeah. I don't see any other questions here, do I? So we have people from Spain, Nigeria. So this is very helpful to us. Okay, so I think we're probably done. I don't see any more questions popping up here. So thanks everybody again, and a special thanks to Atul and to Lucas for joining us. And please go to the ICIS website and you can see all the upcoming webinars that we're having, and then you can sign up to get notifications of when to register for the upcoming ICIS meeting next September in The Hague in the Netherlands. So thank you both very much.
Thank you very much.
Bye-bye. Bye-bye. Bye-bye, everyone.